Welcome to the deep dive. We're tackling a really common health issue today, especially, as we get older. It's the narrowing of arteries to the kidneys, atherosclerotic renal artery stenosis. Now, you might think the fix is straightforward, just open up the blockage, right? But the best approach has actually been surprisingly unclear for a while. So this deep dive zeroes in on a key study, the CORELL trial, to reveal, well, a crucial insight. For most people with this condition, intensive medication, not necessarily a stent, seems to be the most effective path to prevent serious outcomes.
Exactly. And for years, stenting, putting that small tube in to prop the artery open, it was a pretty common treatment. And
Yep.
sometimes it did seem to help, particularly with blood pressure. But then larger, more well-conducted studies started to cast some doubt on the overall benefits, especially for kidney function itself. That's really why the CORAL study is so important. It was designed to give us a clearer answer.
Okay, so before we really dig into CORELL itself, maybe let's set the stage a bit more. Why was this study even needed? You mentioned those earlier studies being less conclusive. What were the sort of lingering questions?
Well, some of the initial research, maybe back in the 90s,
Mm.
it did suggest stenting could lower blood pressure and maybe, just maybe, improve kidney function. And that led to the procedure being used, well, quite a bit more often. But then came these more rigorous trials like ASTRAL and STAR. And they just didn't show those same benefits in the long run. They didn't find a significant advantage for stenting when it came to blood pressure or kidney health outcomes. So that created this real uncertainty in the field. And that's the gap CORAL aimed to fill.
Right, makes sense. So with all that background, what specifically were the CORELL researchers trying to figure out? What was their main question?
The CORAL trial's primary goal, its main aim, was to see if adding renal artery stenting to the best available medical therapy could actually prevent major adverse events, events affecting the heart and the kidneys. And crucially, the people they studied had atherosclerotic renal artery stenosis. Plus, they also had either high blood pressure needing multiple meds, or they had pre-existing chronic kidney disease.
Okay, so it wasn't just anyone with some narrowing. The focus was on people with these additional significant health challenges.
Got it. So how did they actually investigate this? What did the study look like? The design?
CORELL was what we call a prospective, multi-center, randomized controlled trial. So prospective means looking forward in time, multi-center, lots of hospitals involved, and randomized controlled means they randomly assign participants to one of two groups. One group got comprehensive medical therapy plus a renal artery stent, and the other group, just the same intensive medical therapy on its own.
And how many people were involved? Was it a large study? Oh, yeah, it was pretty substantial. They initially screened over 5,000 people. And ultimately, 947 participants met all the criteria and were randomized into the two groups. And it's important they made sure the two groups looked very similar at the start. Baseline characteristics were well matched. Then they followed everyone for a median of 43 months. That's a good chunk of time, over 3.5 years.
Right, okay. So two groups stent plus meds versus just meds followed for a good long time. Now, who exactly were these 947 people? What were the specific criteria to get into the study?
Yeah, the inclusion criteria were quite specific. They had to be adults, 18 or older. And they needed significant narrowing in at least one renal artery. Now, severe stenosis was defined a couple of ways. Either at least 80% blockage seen on an angiogram, or between 60 and 80% blockage if there was also a significant pressure drop across that narrowing, at least 20 millimeters of mercury difference. They also allowed other imaging methods like ultrasound, MRA, CTA to identify severe stenosis based on specific criteria like flow velocities or the degree of narrowing with certain visual features. Basically, they used multiple tools to make sure the stenosis was genuinely significant.
Okay, that's pretty clear. Significant blockage was key. What else did they need to have?
Well, besides the stenosis itself, participants also had to have one of two other things going on, either hypertension, high blood pressure that needed two or more different medications to control it, or they had chronic kidney disease, CKD, stage 3 or higher, which means their kidney function, the eGFR, was below 60. And importantly, that kidney disease had to be considered related to the renal artery stenosis, even if maybe they didn't have hypertension.
Okay. Were there reasons someone with stenosis in one of those conditions might have been excluded, turned away from the study?
Yes, definitely. There were several key exclusions. For instance, if the narrowing wasn't due to atherosclerosis, like if it was caused by fibromuscular dysplasia, FMD, they couldn't participate. Also, if their kidney disease had another clear cause, or if it was really advanced, like serum creatinine over 4.0, they were out. Other things included kidneys being too small, less than 7 centimeters, or if the stenosis itself wasn't technically treatable with a stent, or if the renal artery was too small or too big for the available stents. And of course, allergies to contrast dye or essential meds like aspirin or clopidogrel were also exclusions.
All right, so a very carefully selected group. Now let's get into the interventions. What exactly did this comprehensive medical therapy involve for everyone?
Yeah, this is absolutely crucial. Both groups, remember, got this comprehensive multifactorial medical therapy. And this wasn't just, usual care. It was a very deliberate, intensive approach. Every single participant received antiplatelet drugs like aspirin or clopidogrel to prevent clots, and they were all prescribed antihypertensive medications. The study specifically mentions using an ARB, candesartan, often with the diuretic hydrochlorothiazide, plus a calcium channel blocker and a statin combined, amlodipine atorvastatin, for cholesterol. And a key point, these specific medications were actually provided free of charge to participants.
Wow, that's quite a regimen. And I assume the doses weren't just fixed, they were adjusted.
Exactly. The studied doctors actively managed these medications. They carefully adjusted dosages for each person. The goal was to hit specific blood pressure targets, usually below 140/90, but even lower, 130/80, for people with diabetes or certain kidney issues. And they also managed cholesterol levels according to standard guidelines. So it really was optimized proactive medical care for everyone in the trial.
Okay. And then for the group that also got the stent, what did that procedure look like?
Right, so for those randomized to the stenting group, they had a procedure using a specific type, the pulmogenesis stent. It was placed in the narrowed renal artery. Sometimes the doctors would predilate the artery with a balloon first, sometimes not. And if someone had blockages in, say, both renal arteries or multiple spots, they might get multiple stents. This could happen in one procedure or maybe over a couple of procedures within a few weeks.
Okay, crystal clear on the who and the what. Now, the big reveal. What did CORELL actually find? What were the results? Did stenting help?
Well, this is the main takeaway. The study looked at that primary composite endpoint, remember, that mix of bad outcomes. Cardiovascular renal death, heart attack, stroke, heart failure hospitalization, worsening kidney function, or needing dialysis. And the headline finding was, there was no statistically significant difference between the two groups. In the stent plus medical therapy group, about 35.1% of people had one of these events. In the medical therapy alone group, it was 35.8%. Really very, very similar outcomes.
Wow, those numbers are incredibly close. Can you unpack that no statistically significant difference a bit more? What does that mean practically?
Sure. So they calculate something called a hazard ratio. It compares the risk in the stent group versus the medical therapy group. Here, the hazard ratio was 0.94. A value less than 1 suggests a benefit for stenting. But the 95% confidence interval, that's the range where the true effect likely lies, went from 0.76 up to 1.17. Since that range comfortably includes the number 1, which means no difference, and the p-value was 0.58, which is much higher than the usual cutoff of 0.05, we basically conclude that the tiny difference they saw was probably just due to random chance, not a real effect of the stent.
Okay, so for that main combined outcome, no clear win for stenting. What about the individual pieces, like just looking at heart attacks or just kidney failure? Any difference there?
Nope. They looked at all those individual components separately too, and also looked at death from any cause, all-cause mortality. And again, no statistically significant differences found between the groups for any of those specific outcomes either.
Huh. So across the board, for the really serious stuff, adding a stent didn't seem to move the needle beyond what good medical therapy achieved. But I think I recall reading something was different, something about blood pressure.
Yes, that's right. There was one secondary finding that did cross the line into statistical significance. The group that got the stents, they did have a consistently slightly lower systolic blood pressure. That's the top number throughout the study. On average, it was about 2.3 millimeters of mercury lower in the stent group. And that difference, though small, was statistically significant. The p-value was 0.03, and the confidence interval stayed below 0, just barely.
Okay, so a small statistically significant drop in systolic BP with the stent. Interesting. Now, when experts looked at this whole study, what did they make of these findings? Did they point out any limitations or emphasize particular implications?
Yeah, there were definitely some important discussions around it. One point, which the authors themselves noted, was that the study included people with stenosis starting at 60% narrowing, so moderate stenosis. And there's always been some debate about whether stenting really helps much at that level versus more severe blockages. Although, interestingly, they did do a sub-analysis just looking at those with 80% or greater stenosis. And even in that more severe group, they still didn't find a significant benefit from stenting for preventing those major events.
That's important context. What else came up in the analysis?
Well, they also highlighted the exclusion of patients with fibromuscular dysplasia, FMD. As we mentioned, that's a different condition. And for FMD, stenting is often thought to be more clearly beneficial, especially for controlling really tough high blood pressure. So these results don't apply there. Another potential issue raised was something called crossover. Some doctors treating patients in the medical therapy only arm felt strongly enough that their patient needed a stent that they withdrew them from that arm and gave them one anyway. It wasn't a huge number, but it could theoretically slightly dilute any potential benefit seen in the medical therapy group or mask a benefit in the stent group. It adds a bit of noise.
Ah, right. That kind of real-world clinical decision-making can complicate trials sometimes. But what was maybe the biggest takeaway message from the expert commentary or from the authors themselves?
I think the most crucial point, really emphasized by the authors, was just how good the results were in both groups because of that intensive medical therapy. They called the results remarkable. They stressed that even in this population, older folks, lots of high blood pressure, diabetes, existing kidney disease, this optimized medical management alone did a fantastic job. Using that specific combination, the ARB, maybe a diuretic, the calcium channel blocker, the statin, the antiplatelet, that cocktail really controlled risk factors well and led to good cardiovascular and kidney outcomes, relatively speaking.
So it sounds like the real star of the show might have been the high-quality medical therapy itself.
Absolutely. I think that's a fair assessment. CORELL, along with trials like ASTRAL and STAR, really helps paint a much clearer picture than some of those earlier, maybe less rigorous studies suggested. The evidence from CORELL strongly indicates that for most patients with atherosclerotic renal artery stenosis, adding a stent on top of really good comprehensive medical care doesn't significantly add benefit in terms of preventing these major heart and kidney events.
Okay, so let's try to boil this down for everyone listening. What's the key message from the CORAL study if you or someone you know has this condition?
The main takeaway, I'd say, is this. If you have atherosclerotic renal artery stenosis, along with either high blood pressure or chronic kidney disease, the absolute cornerstone of your treatment should be excellent comprehensive medical therapy. Adding a stent doesn't seem to significantly lower your risk of major cardiovascular or renal problems, even though it might lower your systolic blood pressure just a tiny bit.
And it's really worth hammering home that point about the quality of the medical therapy in the study. This wasn't just taking one pill.
Exactly. The study really highlights how crucial it is to aggressively manage blood pressure, cholesterol, and clotting risk with the right combination of medications, all carefully adjusted and monitored for the individual patient.
Right. So it leaves us with a really interesting thought, doesn't it? Given how effective this intensive medical therapy proved to be on its own in CORAL, well, it really makes you question what are the specific circumstances, if any, where renal artery stenting does still offer a clear, substantial benefit, a benefit big enough to justify the risks and costs of the procedure. That's definitely something for you to ponder, and it's a nuance the medical community continues to grapple with. Thanks for taking this deep dive with us today.